I'm going to now carry on sort of from last year when I talked about how to think about combining therapy, but now really think about the practicalities of this approach. So here are my disclosures. So what I'm going to do is first briefly discuss what combinations are possible. We've heard a lot about that, think about some of the rational choices, and then really focus on the approach to evaluation and use some development, particularly in Hep C, to give us some lessons about how to evaluate efficacy and safety. So we've already talked about these long list of potential virological and immunological targets, and I'm not going to spend any time going through them, but just to show you that there are a lot in both categories. And in theory, you can combine different viral targets, different immune targets, a viral with an immune, and I've given some examples here. And this was actually the slide that I finished with last year where I said, you know, you probably want something that suppresses viral replication, want something that depletes protein to hopefully improve immune function, and then this sort of knockout punch with an immune target. And maybe you don't need all three classes, and the specific ones I've listed here are not the only options. And really, in the discussion, the point was made, well, this is true, but then you've got a lot of combinations. So if you start mixing and matching all of these combinations and you think about trying them all, you quickly run into a bit of an overwhelming task. So the key questions really are on the efficacy side, how much proof do we need for each agent when you're starting to combine approaches? So do we need clear value of each agent, or can you assume that one will be useful? And then do we need different endpoints for different targets? And we've talked a bit about endpoints today, and I think this is a really critical point because measuring efficacy is not such a straightforward thing in hepatitis B. And then safety for each agent versus safety of the combination. And so you start with the sort of simple scenario of taking two approved drugs. You've got proven efficacy and proven safety of two drugs, and then you have a trial where you put drug A plus B versus drug A versus drug B alone. And to be honest, this has only finally been done a couple of years ago with the agents that we have, with a fairly robust trial of PEG and TDF versus TDF or PEG alone. But even here, there are some challenges about which population you study, and even within that, things like genotype, whether the duration of treatment for the different drugs matters. And you saw in that trial, there were different durations of the interferon, so not so simple to design or to interpret. Then you have potentially different endpoints. The major endpoint in that study was focusing on surface antigen loss, and as Harry showed this morning, it did improve it, but not probably enough to justify using them. And then the reality is, the reason it took so long to do this, it's a big trial. You've got these two drugs combined plus each drug on its own. It ends up being a 3-arm trial, and that's not so simple to do. So even with the very simple scenario, it's difficult. But this gets much more difficult when you start to think about studying new agents. So let's just say, assuming you need a 3-target paradigm. So you've got drug A, drug B, drug C. For each of them, you have to figure out the dose. Then you've got to have some measurement of activity and safety, and then you've got to think about combining them. So you've got to do A plus B, A plus C, B plus C, and only then think about A plus B plus C. And that obviously becomes a very complicated procedure, and it gets more complicated if there are drug interactions between these agents, if there is a preferred dose or duration or population that isn't clear. So from your initial studies, if you don't clearly show that one of these doses is clearly better than another, that may be a challenge, or if you have to figure out the duration or population, or more importantly, which endpoint to study. So clearly some major challenges in terms of evaluating the efficacy. And then even the idea of combination therapy, you could interpret this a few different ways. You could have sequential therapies, so A then B, or B then A, or you could have A and B together, or you could do A and then A plus B. And of course, that gets more complicated when you add in a third drug. And so I've just shown that at the bottom, where you have drug A with a few different doses, and then you do drug A plus, in this case, just a nuke with an approved drug. And you can see even that isn't such a simple design. That gets much more complicated when you have two new drugs. So let's just take a look at Hep C to give a few lessons and a few cautions. So a few good examples, and I'll also talk about the rapid assessment of efficacy, which allowed some things to move forward relatively quickly, some scenarios where things were better than expected, and then a few bad examples where really forgetting to evaluate the value of each agent in a combination insisting on your own pipeline, and unexpected toxicity. And all of these things really play into thinking about design. So when you want to, I think this was an important study, and Ed Gain led a lot of the development in hepatitis C for many reasons. One, because he's a good investigator, but also because the New Zealand regulatory environment is a little more liberal than the FDA and EMA, and they allowed him to do these, I think, very helpful studies where you see that what he did is combined so different targets, a polymerase inhibitor and then a protease inhibitor, so it was brief monotherapy and then combination therapy in both directions. So first the polymerase, then the protease, first the protease, then the polymerase, or the combination from the start. And this is really helpful in showing the specific efficacy of each of the agents and the benefit of combining them. And in theory, there was a lot of concern about doing this because you might select for resistance even in a very short exposure to monotherapy. So this should be more easier to do in Hep B because of the higher barrier to resistance. But the biggest challenge for this is you can see that these are just 3 days of monotherapy. If you want to look at endpoints other than HBV DNA, this is going to take a long time to see an effect, and so it's much more challenging. But the other big challenge here was that this was not allowed to be done in most countries in the world, and it was really that the FDA and EMA and other regulatory bodies then jumped on the back of these studies to further them, but the initial development was done in New Zealand. But see, so that was a good example, but if we flip now to maybe a bad example, and I'm just using these as examples, but this is an evaluation of 3 different drugs for Hep C, a protease, an NS5A inhibitor, and a Nuc, and these just happen to be the Merck compounds, but the reason I'm highlighting this is first I want to show you the efficacy, and you see that these drugs are incredibly efficacious, almost 100% cure rates in these difficult to cure populations. So you'd think this would automatically lead to a phase 3 study when you have phase 2 results like this, but the FDA came back and said to Merck, okay, well, this is good, but before you go to a phase 3 study, are you sure that 2 out of these 3 drugs actually wouldn't be adequate? Are you sure you need all 3 drugs? So they then had to go back to the drawing board and look at just 2 of the drug combinations to make sure that in fact their 3rd drug was adding additional benefit, and that really led to major delays and actually might have killed their program in the long run. And so it's just a cautionary point that you really need to make sure before you combine 3 drugs that you do in fact need that each drug actually adds incremental efficacy value without any consequence in safety. Another key point that I think, and this is, I've used, again, one example here, but there would be many that could have been used here, is to think about the value and not to choose agents just because you happen to have them in hand. And unfortunately, I think BMS here is a bad example where they developed 3 drugs crossing 3 different classes of Hep C drugs. So a very good pan-genotypic NS5A inhibitor, a less good and somewhat toxic protease inhibitor, and a non-Nuc polymerase inhibitor. And so you could look at this and say, well, maybe it's a great portfolio, or maybe it's just one great drug. And the challenge here is that by insisting on developing their own combination rather than partnering, really probably led to declatosphere taking a lot longer to get approved, and not being as widely used as it might have been. And so I think this is just a cautionary point. I'm actually optimistic this won't happen in the Hep B space as much, partially because there is a lot of the companies are smaller that are involved, and so they may need to work together to develop drugs. But I really think this is quite important, and I would actually encourage regulatory agencies to insist upon collaboration to use best-in-class drugs rather than what drugs you have in hand. So a second good example is, I'm going to use a hockey analogy, when things turn out a little better than expected. So this is a good example, but a bit of a cautionary tale, and I'm going to use a soccer analogy here. So you can take a decent soccer team. The U.S. isn't bad. It's reasonably effective, although maybe less so, not making the World Cup this year, I understand. And then you can take and we'll say that this is sort of like interferon for Hep C, and then you can take a completely useless national team, and this is sort of like ribavirin as monotherapy for Hep C. It really does basically nothing. And then somehow you put these 2 together and you get Brazil. And why does that work? Now, I will say you didn't get Germany, so it's not that good, but it's still pretty good. But I think this actually is a challenging precedent because you had a very modestly effective therapy combined with a therapy that was effectively had no activity as monotherapy. And so you could even question why this was ever tried. How would you know to do this again? You take one sort of good and one useless and put them together. And the challenge then is this sort of argues against the you have to prove that each component works. You have to prove it adds value, but not necessarily that it works on its own. And so this makes the case for rational combinations for which each component is safe, whether it's effective or lone or not, but it does add one extra layer of complication to studying these and designing studies in thinking about how to take a drug that you think will add benefit but may not work well as monotherapy. And then once you think about forgetting about the drugs themselves, the biggest challenge to not only combination therapy but even monotherapy is really endpoints and populations, and these really might be the biggest issues. So we've talked about endpoints a little bit today, and when you compare this to other diseases in Hep C and HIV, it was pretty simple. Basically, the endpoint was viral load, so it's pretty easy to measure. It changes rapidly. Your goal is to get it undetectable, ideally in the body, but the serum is a pretty good marker, and so this is really a pretty useful tool. Now for Hep B, we've got this long list of surrogate endpoints, starting from Hep B DNA, which is often used as the clinical marker, but we've talked today a lot about the fact that surface antigen is probably a more useful marker, and then you can look at these other factors, of course cccDNA being very important, but very challenging to measure. So is there consensus? Well, Fabien told us this morning about the conference last year and this discussion between sterilizing cure versus an off-therapy sustained response, and really most people have settled on this idea of functional cure with surface loss, undetectable DNA, and normal ALT, and this was actually the endpoint that was favored by the majority of attendees at the EASL-ASLD Endpoints conference last year. So this has sort of become the target, and we certainly talked about that today, but let's just think about some of the caveats with surface antigen. So this, of course, could mean different things in different populations, and if you use different drugs to do this, even using surface antigen loss as your endpoint, which seems like a very robust endpoint, it might actually mean different things, and we've touched on this a bit today. What we're aiming for is what we see and what we think is in natural clearance, that you've either got complete clearance of cccDNA or at least silenced cccDNA. So this is sort of what we're aiming for with therapy. And if you target cccDNA, like we heard, as a possible approach, but nothing really in development yet, that's probably what we're doing in that scenario. But what about if you do siRNA? You block translation of the viral protein. It probably has no effect or a limited effect on cccDNA transcription unless it leads to upregulation of the immune response. So it's unclear if that really means the same thing. You could see surface antigen clearance, and it may actually not really reflect what you think you saw, which was silencing of cccDNA transcription. If you have an immune target, probably this is a pretty good endpoint. It probably means that you have immune control. But we also have the concern that you could have a false negative. If you have integrated DNA producing surface antigen, even in people who have cleared or silenced all cccDNA, someone who's E negative with undetectable DNA may still be surface antigen positive in their serum. You come to the conclusion they didn't respond when in fact they've actually cleared or silenced all cccDNA in their liver. And this is again a problem for just interpreting results. But the bigger challenge is probably that the decline is slow, so you probably need a long-term therapy to see an effect, and this is probably even more true if you're really getting true silencing or clearance of cccDNA. So the challenge here is that you want to avoid excluding a good drug just because you don't see a rapid fall, and most trials, at least initially, and at least for monotherapy, begin with very short studies where you may not see this effect. And if you do see the effect, then what matters? Is it a half-log reduction, a full log reduction, or actually clearance? And we might have similar challenges if you look at other markers of what we believe to reflect cccDNA transcription. We heard about HBV RNA and core-related antigen. But what they mean in a particular context and with a different mechanism of action of your therapy really may differ. So this is a bit challenging, and really you may end up with struggling with needing a different endpoint for each of your different targets. So if you have a virological target or an immunological target, you may actually have to look at different endpoints. And so the other thing is that you really may need proof of concept early endpoints. I think sometimes even including the liver. Georg focused really more on understanding the immune system in the liver, but we also need to look at the hepatocytes, I think, as well. And I give the example of a RIG-I agonist, where we saw today pretty nicely from Adam and others that you can see ISG induction with this drug, even though there was a fairly modest effect on surface antigen decline. So it's doing what you want it to do, and you need to know that, because you may want to improve the therapy or then add it with something else. And if you just looked at the clinical endpoint of surface decline, you might discard an agent which is actually active. And then, of course, when you go into phase 3 trials, you're probably not going to use a liver biopsy, and you need to look at clinically relevant endpoints. So if you look at the population beyond endpoints, again, with Hep C and HIV, it's pretty easy. The only thing we really had to worry about in Hep C was different genotypes and people with or without cirrhosis, and you start in the mild patients at the beginning. But in Hep B, we've got all these different phases of disease, and as we heard from multiple speakers today, figuring out which therapy is most appropriate in which phase may not be so easy. So certain therapies may work extremely well in one phase of the disease and be totally inactive in another phase. I think Mala gave the example of a therapeutic vaccine not working in someone with a totally exhausted immune system, and that would be an example where that might be useful in someone with a more active immune function. And then the other question that comes up is, do you want to study these patients in someone who's nuc suppressed or not nuc suppressed? And I think this is a key question when you start doing your initial evaluations of therapies. And there's pros and cons to both. Harry touched on this morning. On the pro side, seems safe. You intuitively makes sense. You think these patients are less likely to have a big flare. Maybe there's a clinical need because these patients had some indication for therapy, so that would, at least they need something. And maybe there's an additive or synergistic effect. So DNA suppression may help whatever other mechanism is being evaluated, either by slowly reducing antigen production or other mechanisms. And the other practical point is that these are the easiest patients to find. We all have clinics full of patients that are nuc suppressed. The downside of using nuc-suppressed patients is potentially safety. So flares still may occur, but the significance of what those flares mean is actually not as clear. You might miss an effect. So if a therapy requires active replication for you to see the effect of what you're targeting, you may miss this. And an important thing is you actually lose HBV DNA as an endpoint, because it's usually undetectable before you start. And then you have additional drug interactions to consider. So DNA can give you useful information, and I just use this again looking at a RIG-I agonist here as an example, and this is a woodchuck study, but what you see here is on the right is you see the suppression of HBV DNA levels, and on the left the reduction in surface antigen titer, and you can see that if you just looked at surface antigen, you'd say there was a pretty minimal effect, whereas there was a more robust reduction in HBV, or well, in this case, woodchuck DNA, suggesting that the drug was actually active. So if you had done this in nuc-suppressed patients, you would miss that activity and might again forego the drug. So the bottom line, when we think about efficacy, it's really not simple to measure. Different agents with different mechanisms may be very challenging. You can't always predict the combinations or the outcome of combinations, and the combination that you should choose should not really be just the one that you have in-house. And I hope I made that case that was a fatal mistake, at least in Hep C. And then the endpoints and the populations continue to be a challenge. So then we move on to safety, which might be the bigger issue with combination therapy. So the first one is drug interactions, and at least in theory, this is relatively straightforward. So it's not so difficult to predict drug interactions. And doing drug interaction trials is simple to do, but it's important to recognize they're not cheap, and especially for smaller companies, this can be a major impediment to getting things moving. But fortunately, drug interactions can be largely predicted if you know the metabolism of the drug and the elimination of the agent. And then you sort of have to start with initial healthy volunteer studies with standard PK measurements, and then you go on to evaluate whether or not this has an effect when you study it in patients with liver disease. So this can be done, but it's not always easy, and arguably it may not always be necessary to look at every single combination of drug interactions if there's nothing predicted. And for example, for a lot of the nukes, there's really no anticipated interaction with most of the agents in development, so maybe you don't need to do these drug interaction studies. And I'll come back to this in a moment because I'll just talk about what the FDA has said about this. But the bigger challenge than drug interactions is really toxicity. So flares are probably our biggest concern, and this is complicated. And I'll start with everything else, which is really thinking about what you would do in evaluating toxicity of any drug, so not Hep B therapies specifically, but when you use combinations, it's quite challenging to sort out what's doing what. So if you think about a non-hepatic adverse event with combination Hep B therapy, so let's just again take the example of drug A, B, and C, and you have a non-hepatic adverse event not seen with any monotherapy. So you did all your monotherapy studies, they were clean, you put them together, and then you suddenly see this event. Now, what's the conclusion? Is the type of, so sometimes the type of adverse event might help you. So if you're using an immune targeting drug and you have what seems like an immune mediated event, then you could probably point to the target. That might be more likely to be a PD-1 blocker than a capsid assembly modulator. But even that isn't necessarily certain. You can get immune reactions to non-immune targeting drugs. But then is what you're really trying to figure out, is this an idiosyncratic reaction from A, B, or C that you didn't see in a small, relatively short duration monotherapy study, or is this a result of putting them all together? And that's not simple to pull apart. And then even more importantly, is this a class effect or is this a drug-specific effect? And again, a lesson from Hep C is that when the BMS HCV nucleotide polymerase inhibitor was evaluated, animal studies looked pretty clear, but they were short. And then when it went into human trials, clear phase 2 trials, and then going into a phase 3 study, 1 cardiac death and 8 patients with severe cardiac failure, this really ended the development of that drug and really moving forward. And the FDA has said very clearly that the lesson from this is that you do need to do chronic animal toxicity studies before you is critical before you put them in a combination. So you really need to know the safety of each drug given for a long time in animal studies. These are expensive studies, but I think the FDA has had a bit of a jaundiced view after this experience and has really pushed that this is a clear point, and I'll show you where they've said that. So now if we think about specifically liver flares, because this is really a special problem. So we have 3 potential kind of flares, sort of our immune-mediated flare, which might lead to viral clearance, and that's what we want, sort of the good flare, drug-induced liver injury, or on autoimmune-type hepatitis. So this immune-mediated flare, we think this is usually related to viral control, and this might lead to E or surface loss, so this is really what we want to see. Usually these tend to be self-limited, but even flares in natural disease can be quite severe, and very rarely can be life-threatening. So this is sort of what we want to see as long as it's not too severe, and the nice thing here is that if you see this type of flare in someone not on a nuc, a nuc might help. For drug-induced liver injury, this is idiosyncratic or dose-dependent. Some depends on the agent and sometimes hard to predict. Most of the mechanisms for it are unknown. Hy's law, the standard rule for applying liver injury when you look at new drugs, is really difficult to apply when you start out with an elevated ALT, which is often the case in patients with active hepatitis B. And these can be very severe or even fatal, and for most things we don't really have specific therapy, so really a challenge. And then finally, the autoimmune hepatitis type scenario, this is probably only with the immunotherapies like the checkpoint inhibitors. These seem to be very rapid onset, at least from the oncology literature, and they can be very severe or even fatal, and they're steroid responsive, but that might impair your hepatitis B treatment if that's your goal. And then, of course, the same issues of trying to figure out which drug caused what would apply here as well as to the other scenario. So I just want to show you a couple of ALT flares and just show you how just to show you how these look. And this is an example, you've heard about this nivolumab trial, and just highlighting the one patient who had this anti-PD-1 inhibitor who was already nuc suppressed on tenofovir, and you can see that this individual in red, the ALT went up, and then in blue you can see that the surface antigen titer fell and that the patient cleared surface antigen. So this was sort of what you want to see, a modest ALT flare that was not icteric, and the patient cleared surface antigen. So that's sort of the good scenario. But figuring out if you didn't see this, if you were trying to tease apart drug-induced liver injury, is how do you interpret this? So there was a workshop to develop stopping rules for hepatitis B flares, and actually the workshop really didn't reach a consensus. They said if you start out with elevated baseline ALT at different levels, and you can see them there, 1 to 2-fold, 2 to 5, or greater than 5-fold the upper limit of normal, that then you look at increased elevations compared to baseline, and that seemed reasonable. But this might be one argument for thinking about nuc-suppressed patients, is they generally will start with a normal ALT, so you can at least evaluate drug-induced liver injury. A little bit tricky. So would a biopsy help? Not really clear. The FDA, interestingly, at the HBV forum at EASL this year, said that they thought it was of limited value. They felt it was invasive and too non-specific to distinguish. I'm not sure I agree, because in addition to potentially clarifying the cause of the ALT flare, it might also give us some idea about activity of the drug that we're evaluating. So I think it's still a helpful thing to consider, and I think we should probably be thinking a little more about doing biopsies in the setting of ALT elevation in patients on combination therapy, but I'm not sure if others would agree. Now, I want to show you about some other ALT flares where it's not so clear. I showed you that one where it was a good flare. What about this? So this is a study that we did with the Hepatitis B Research Network, and this was in immune-tolerant patients who received a lead-in with entecavir for 8 weeks and then had add-on peg interferon for an additional 40 weeks in these patients that were immune-tolerant at baseline, so effectively a normal ALT. And you can see that what happened over time is you see that their ALT increased a number of patients into this range, 150 to 200 in a number of patients. It occurred in about 2/3 of the patients. None of them were that severe. In some, it was associated with a drop in surface antigen, but not in everyone. Are these good or bad? We don't know. What do they mean? What is actually happening? So these are completely nuc-suppressed patients, and yet they're having an ALT flare caused by interferon that it's not so clear what it means. And I think trying to understand what this means is useful, but it really makes a challenge, and it's also challenging for clinicians if this ends up being a therapy, is when do you worry if we're not really sure what's going on? Now, sometimes these actually can be helpful in terms of figuring out how to combine your drugs. So again, I'll go back to the RIG-I agonist, and you can see in these two different approaches, give the nuc first and then the RIG-I agonist, or give the RIG-I agonist first and then the nuc. And so what you see is in the black bars here are ALT elevations, and here is the decline in woodchuck hepatitis virus level. And so what you can see is during the nuc, you see good suppression of woodchuck hepatitis virus, and during the period of getting the RIG-I agonist, you see these ALT flares. So what looked like this was a preferred strategy because you see the DNA decline, the ALT flares, but then when you added in the nuc, you actually rescued and suppressed those ALT elevations. So doing this pretty small animal trial then clarified how to move forward into a human clinical trial, and this is actually how they're going forward, is to give this drug first, followed by the nuc. So I thought I would finish just with some guidance from the FDA, and this is just a summary from a meeting that took place between the Hepatitis B Foundation, the HBV Forum, with members of the FDA Division of Antiviral Products that was earlier this year. And the FDA said at this meeting that they plan to put forward a document for HBV drug development, which was supposed to be ready at the end of this year, but it sounds like it will be early 2018. And just some key points that were made from this, and this just as a caveat, this is a summary that Tim Block and Nat Brown made from this meeting, and they acknowledge this is just their memory of the meeting, but I just wanted to point out some of the points that they put in this summary document. First of all, the populations to study. So although the FDA thought that studying naive patients is important and a preferred strategy, they felt that nuc-suppressed patients are much easier to find, so probably all evaluations should be done in both groups. For drug interaction studies, they said that they were not required for all add-ons to nucs if there was no DDI expected. So that's quite important, I think, but that they were probably required for all other types of novel therapies. In terms of duration, so the standard early phase 1 trials are usually only 4 weeks, but the problem is as I told you, if you're looking for an efficacy effect with a slow response, you might miss something at 4 weeks, which was quite effective. So they said that if you had good preclinical animal data that supported giving therapy for longer, that you could extend these proof of concept studies out to 12 weeks, and this is unique to Hep B so far, so that's, I think, an important point that they made. And then the final thing, and I made this point before with the toxicity, but that combination tox studies in animals are really critical if you have more than one new agent being put into a combination. So finally, to summarize, both efficacy and safety are a major challenge with multiple new agents developed at once. There's added complexity with various endpoints and populations to study, and so choosing the right combo in the right patients for the right duration will certainly be challenging, and even if the science is perfect, we'll probably need innovative approaches to trial design to evaluate this, and I think Dr. Chan is going to tell us how to do that. So a good entry into to Henry's next talk. Thank you very much.